Good morning, guys.
What's everybody doing?
I'm awesome.
Morning.
Yeah, doctor, how are you, sir?
Great, thank you.
Yeah. So we've got a lot of names here. So Jonathan Kaplan is your given name, but Dr. Well, I believe, is where you're kind of at these days. Is that
Dr. Bay.
Yeah, that is Dr. Bay. We got
exactly.
a couple of them here.
So Dr. Well is the company that I have now that deals. It's a provider to consumer platform, that kind of a competitor to a direct consumer platform. Anyway, that's Dr. Well. But then yes, on TikTok, for that side of the business, I'm Dr. Well. But on the private practice side of my life as a plastic surgeon, I'm Dr. Bay, real Dr. Bay on social media. So because I'm in the San Francisco Bay Area, so depending on what hat I'm wearing, I'm either Dr. Well or Dr. Bay.
Sure. Let me ask you along that. You kind of teed up this question perfectly.
Yeah.
Like, did you ever think in a million years that as a doctor or medical professional, you'd have to worry about your fucking TikTok handle? Like, did that ever even occur to you?
I mean, I'm not at all. I mean, like, because we were talking about, like, when you're in med school, we knew that there's some business aspects of being in healthcare, and we talked about how med school didn't teach you anything about business, but they certainly didn't teach you anything about social media. They certainly didn't teach you anything about marketing. So yes, my learning curve has definitely been very steep over the course of my career from a marketing perspective.
I mean, isn't that crazy?
I was expecting.
I went to art school, and like they didn't tell you that when you get out of art school that like you're gonna have to write a contract to sell your services so you could actually pay your mortgage. And I'm like, first like freelance gig I ever got, they're like, oh, do you have a statement of work? I'm like, the fuck is that? Like, I have no idea what you're talking about.
Right.
And like, why did nobody tell me about this shit? Like, this is terrible.
And when it comes to healthcare, I mean, it's like you certainly don't know anything about a contract, but so much has changed in healthcare. I was in med school in the late 90s, like graduated 2000. So the way healthcare has changed over that period of time, I mean, the fact that most providers are not in private practice anymore, that used to be go out, hang your shingles, what people would say. But now so many providers are employed. Funny enough, whenever I went out into private practice in 2007, after I finished my plastic surgery training, I became an employed physician at a hospital in Louisiana, and that was very new there, especially as a plastic surgeon. And then my brother, who was a vascular surgeon, was in private practice in 2007. My brother-in-law was a bariatric surgeon who was in private practice.
Oh, wow.
And they were giving me a hard time about, you sold out, you became a suit, you went, your first job out of training is an employed physician. Fast forward to 2013, I move out here to San Francisco with my wife to go into private practice, take over an existing practice. And by that point, my brother and brother-in-law had become employed physicians.
Yeah, kind of got gobbled up.
Yeah,
was that one of those where like the big hospital came in and said, "Hey, we're going to take over here"?
Well, I mean, because the doctors, they were doing well, but they could see the writing on the wall that reimbursement was going down, expenses were going up. They knew it wasn't sustainable, and the only way they could survive was to be employed by a hospital. The best thing to do, though, is if you're going to have to become an employee of a hospital, be one of the first physicians to become an employee of a hospital rather than the 100th, because you're not going to be able to get a very good contract if you're the 100th.
Yeah, and that's kind of like a shame, isn't it? But I mean, it is sort of a reality, right? You can't, I mean,
Definitely.
we can sit here and poo-poo it all we want, but like, I mean, them's the breaks kind of thing, right? Like, it's just how it functions.
I mean, people always think of healthcare, like it is weird how healthcare, you don't know the cost of anything until after you get the bill, which is like not the way economics usually work. But yes, in the case of like hospitals, doctors, all of that, that's the breaks. That's just economics playing their way out. I mean, that's just the way it is. That's the reality.
Well, and it's also crazy too, because I think you got a lot of people that have figured out how to like massage that system. So like I've got a guy in a networking group that does health insurance plans for companies, and his whole shtick is he'll show you all the ways to not pay those sneaky bills that pop in, like the out-of-network anesthesiologist in a surgery that gives you like a $6,000 bill because it was out of network. And he's like, just call him up and be like, I didn't authorize that. Thank you. Have a nice day. Yeah. And I was like, so how does the anesthetist get paid? Like, I mean, you know what I mean? Like, so in my mind as a business owner, I'm like, well, that sounds great from a hack the system if I'm on the hook for $6,000, but if I'm the anesthesiologist, I don't fucking like you at all.
Well, if he's working for a hospital system, it really doesn't matter. I mean, like I cry about insurance every goddamn day, and I'm only allowed to bill like 4 codes.
Right.
You know, it's like, what did I get paid today?
And that's exactly why anesthesiologists are employed by the hospitals now for that protection. But now your friend, you're talking about your friend, but like that's one of the No Surprises Act that was passed by Congress, went into implementation in 2022. That was one of the things that it did, was to reduce those surprise bills. That like if you as a patient, the bill distills down like this: if you as a patient didn't really have a choice of the provider, they can't charge you an out-of-network rate, which was certainly a reasonable thing. The point being is that if you go in to deliver a baby, you might have chosen your OBGYN, but you don't deliver. You didn't
deliver on that day or that time when he's working. Yeah,
right. But also you didn't choose that anesthesiologist that's going to come in and do your epidural. In the past, they would be able to bill out of network, and you'd be stuck with this huge bill. Like I wasn't in a situation to choose my anesthesiologist.
Yeah,
and that's what the No Surprises Act it makes illegal, is that they still come do your epidural, but it's got to be for an in-network rate, not an out-of-network rate.
I've had so much discussion around that bill, and we never discussed that aspect of it. Doc, I'm an acupuncturist, so we're kind of like out there on our own all the time. But yeah, that was like you gotta be able to say what your treatment costs, is how it was presented to us. But that seems like a little bit more necessary the way that you've just described it, where it's like, I don't want to end up somewhere without the providers that are in network and have no choice,
Yeah, exactly. I mean, it was definitely about, providing good faith estimates ahead of time and letting people know what their out-of-pocket costs are going to be. And then they have to sign something saying that you've told me about those out-of-pocket costs. But then, yes, that's the other side of it, is that if you didn't have a choice or any knowledge beforehand of who your provider was going to be for something, certainly in an emergency situation, they can't bill you for anything, just bill you out of network, just like things that you can't decide on, like who the labs go to, what lab service, they can't bill you out of network for those. Labs, anesthesiologists, intensivists, the people in intensive care doctors, your neonatologist, they can't bill you out of network. Like, I mean, I didn't choose my neonatologist. I didn't go on Google and say, oh yeah, this is a good neonatologist. If I have a preterm delivery, I'm going to go to this person.
That's the one I need. Yeah.
You're like, who the fuck? Most people are like, what the hell's a neonat? Like they don't even know.
This show is so crazy, man. Here we have a plastic surgeon. We're talking about insurance billing.
Yeah. But actually that like totally goes where I want to go. But before we build that bridge, because it's going to go right to where I want to start off with. But like, I just got a bill from Quest yesterday, literally in the mail, because I had all this blood work done for my annual physical. And it turns out that my insurance company only likes LabCorp. And so now I'm like, well, I didn't fucking choose Quest. And if I had known this, I would have just said, hey guys, is it possible that we just send this out the door through LabCorp? I'm sure they have a relationship with them just the same. They probably just flipped a coin or whatever they're, and I'm like sitting there going, and it's not like a ton of money. I think it's like, it's $120 for blood, which I'm like, kind of steep for like annual blood tests that now like the actual cost is like $400, but still I'm like, all right, this should be like a copay situation, I feel like. And if it was LabCorp, it would have been free.
Yeah.
Like,
right, exactly.
So I'm like, well, now this makes me be like, and this is kind of where I wanted to start off. I mean, you have to sort of be like your own lawyer, your own research agent, your own like doctor in training. I mean, hell, you got to go to med school almost to figure out what half this shit even means.
And even doctors haven't figured it out.
Yeah. Which kind of sucks, right? Like back in the good old days, right? For better or for worse, you call the doctor, he comes over with his little bag into your house, fucking does his thing. It's like, take these and, call me in the morning. Now it's like my sister's getting out of the hospital right now with her husband who had colon cancer removed, right? And they're in a public health care situation, like Medicare, Medicaid, kind of thing. And navigating that is a goddamn circus.
Yeah.
Like it is just an absolute nightmare. And she's in your neck of the woods, Doc.
Oh, really?
She's up in Stanford out.
Okay.
Yeah. So
Palo Alto area?
Yeah, Palo Alto area. Yeah.
Okay. Yeah, I mean, that's the thing, is that there's such a gulf in education or knowledge, just such a huge knowledge gap between healthcare providers and patients, and trying to understand. It's kind of like, like going to get your car fixed at the mechanic. I mean, there's a huge knowledge gap there. The problem is with healthcare is that even if you feel like you know about it, then there's some new law or something that passes that you can't keep up with how things are changing so fast. Even the healthcare providers can't. And then the insurance companies are involved, and they can't. They remove somebody from their network, and so you cannot keep up. And as far as your labs go, 120. I mean, I wonder if it's the kind of thing where if you reach out to them and say, "Well, what's the cash rate?"
Yeah, that's what I'm going to do.
Yeah,
I just got the bill yesterday, and
that was the 120.
Same guy. Yeah, that's the same guy.
That's as good as it's going to get. Okay,
probably going to be. But the guy who, that I was telling you about earlier, I can hear his voice in my head being like, call him up and just tell him no and see what happens. And I'm like, okay.
I mean, they probably would negotiate an even better rate with you. It's really kind of crazy.
Yeah, but now I have to do that. That means I got to take time out of my fucking day.
Especially when you have insurance that you feel like,
exactly.
this should have been covered. Yeah.
So how did you get into plastics? Were you always going that direction, or did you discover this? I know that's a little bit of a hard left turn, but it kind of feels like for all the things, you're in an elective field like a lot of times. So like you don't fall under that medical necessity all the time. I'm sure there's components of it. So what got you down this road?
So when I first started all this, I didn't know that there was this cash pay aspect. I didn't understand any of that. And I've taken some other turns in my career that'll be interesting that we can talk about. But yeah, it all started when so my father was a general surgeon. I grew up in a small town, Alexandria, Louisiana. And so from the age of 4, like people would ask me what you want to be when you grow up. And I always said I wanted to be a surgeon. Of course, I didn't know what I was talking about. I just wanted to be like my dad.
Sure.
But as I got older and I realized that how much he enjoyed his career, and he was always home for dinner, like these crazy hours he was working back then. And he was always home for dinner. I continued to want to be a surgeon, and I started to go watch him operate at the age of 11. That was back when they would let you go in the operating room to watch him operate. That was very cool. And then one time when I was about 16, I was in the doctor's lounge with him, waiting to go back to do a case with him or watch him do a case. And one of the plastic surgeons came in and said, "Hey, you want to come watch this case I'm about to do?" And my dad's like, "Yeah, you should. You should go see him do some work." He's a plastic surgeon. So I was like, "Okay, let's go see what this is." And it was not anything cosmetic. What he was doing is the patient had a cancer on their leg. He needed to remove the cancer on their leg, but then the resulting hole was too big to just close up primarily. So what he had to do is take some skin from her neck, from another part of her body, to cover up that hole. But what was so cool about taking it from her neck is that she was this heavy, heavy smoker. She had this really craggly neck skin with all these crevices and wrinkles. And so when he went and took out that skin on her neck, he made sure that the incision was lying right within one of those crevices. So you couldn't even see the scar where he took the skin from. Took that, filled the hole in on her leg. And I was just like totally blown away by how you could use parts of the body to fix other parts of the body. That's crazy. By the age of 16, I knew I wanted to be a plastic surgeon, did all the training for that. Still not really always understanding that was like plastic surgeons did boob jobs and stuff. I was thinking they were doing a lot of reconstruction. And then went through the training, got into, as I got older, obviously got into fellowship at Cleveland Clinic. I realized that there was the reconstructive, there was the cosmetic. And so I went through, finished my fellowship in 2007, went back to Baton Rouge, Louisiana, became an employed physician as a plastic surgeon there for 6 years. And during that time, that's where things took a different turn. That as I was still practicing plastic surgery, I noticed that patients were always calling in asking about the cost of cost of treatment. And there's 2 ways to deal with that. There's either you spend 15 minutes on the phone explaining all the complexities of a cosmetic procedure cost, like the surgeon's fee, the OR fee, the anesthesia fee, cosmetic insurance fee, whatever there is. And then you give them the number, the price, and after 10, 15 minutes of talking to them, they hang up and that's it. Okay, thanks. And they hang up and you've got nothing out of it. You don't know their name, their email address. There's no lead out of that. Or you can say, oh, well, the doctor can't give you an estimate. You have to come in for a consultation. But patients don't want to do that. They don't want to have to come in and bear their deepest insecurities in a consultation to find out the price at the end and find out they've got sticker shock. They can't afford it. So that's why I started this other company that was really all about price transparency in healthcare, which is why I know so much about insurance, even though I don't take insurance. And we started out as a company called Build My Bot, as an iPhone app where consumers could go in and check pricing on different services get real-time eligibility on insurance-based services, cash pricing on cosmetic services, but they only would see the pricing after they put in their name and email address.
Yeah.
So it ended up being lead generation for the provider and instant gratification for the patient to know how much something costs. So that's how we started out.
Are there a lot of
Did you license that to individual practitioners, or was that you had like a network? Okay.
Yeah. We had a network of providers that signed up as a subscription to use the platform, which started out as an iPhone app, as I mentioned, but then we created a price estimator that we embedded into their website that the consumer could also check.
Is that product still around? Is it still?
Oh, yeah. We still support, even though our name has changed and we pivoted a little bit, we still support all the price transparency. Exactly.
So I'm just curious because I'm a business owner myself, like, which these surgeons all seem to be as well. What are the price toggles? Like, what are the influencing factors that could make a boob job go from X to Y? Like, is there?
It's got to be more than just size. Yeah.
Like,
it's
there
primarily location, not location on your body, but location in the country.
Oh, really?
You mean you can't put them anywhere?
Exactly.
I can't just put a boob right here or there. Yeah.
The West Coast is the most expensive.
Oh, wow.
And then the Midwest and South are the least expensive.
Now, why is that? Just demand?
Is that just driving forces that are market?
I mean, you could also argue, demand, but I think it's also just the cost of living. I mean, just like, in San Francisco, the prices for a boob job are going to be so much more expensive because my rent is so much more expensive.
Yeah, for sure.
Yeah. Our staff is so much more expensive. I mean, it kind of, I giggle when I hear about, the new minimum wage is $15 somewhere. And maybe, it's going up from there, of course.
Yeah.
But I giggle because, like, I've never been able to get away with paying any employee in my office here in San Francisco $15. It's always at least been 25 or more.
Well, they've got a 2-hour commute from wherever the hell they live to come to, you know what I mean? Like,
their rent is insane too.
Yeah. I mean,
exactly.
There's
some super commuters.
Well, it's funny, the joke, and with my family, before the show we talked about it, I'm from out there as well, and it's like the joke is it's an hour and a half. What's an hour and a half? Anything. You're like, just whatever the question is. How far to the grocery store? Hour and a half. How far to the college? Hour and a half. How far to work? Hour and a half. Like, it's just like this like unit of measure that feels like very repetitious.
Especially in LA.
In LA. Yeah, exactly. I mean, my parents are like, 2 hours in the car, we'll come meet you. I'm like, on the East Coast where Tom and I are at, 2 hours. I'm like, fuck you. I could be through 4 states in 2 hours. I'm not doing that.
You tell me my commute's more than 20 minutes now, I'm going to have a fight with somebody.
Yeah, no,
absolutely.
Hell no. Yeah.
So that's the one thing that's nice about San Francisco is being in this neighborhood. If we can't walk there, we're probably not going to go.
Yeah, exactly. Yeah. So why don't people, like, if that's the case, I mean, I'm just kind of guessing here, but if I'm a person with means enough to be exploring plastic options, couldn't I just get on a Southwest flight to, Austin or wherever it's a lot cheaper? How come
they do that to Brazil, man?
That's what I was going to say. People take it one step further in medical tourism. They'll go to another country. Turkey is really big for hair transplantation. And I think for those types of things, it's probably fine. But when you get into more invasive procedures, like including a breast augmentation or a tummy tuck, I'm not saying that we don't have complications here in America, but the problem is that whenever you do have a complication, wherever it is, if your doctor is local, they can go and take care of you and they won't charge you anymore. But if you go get your procedure done in another city in the country or another country altogether, and then you come back to the Bay Area and you come to me to fix the complication that you're having, it's going to cost you a lot of money. I mean, I'm going to charge you for that time and effort.
Yeah,
so
we go to Costa Rica a lot. They're half that country is medical tourism. It's crazy.
It is.
I mean, it's like a lot of people down there.
And certainly there's places that are better than others as far as medical tourism because, they feel like that there's some government oversight. There's some, some standards as far as sterility, things like that. And that's the gamble is you don't really know what those standards are. But I think places like Costa Rica have done a really good job of being able to prove their medical tourism is relatively safe. But again, it still comes back to the same problem is you can never predict a complication. And then you're kind of left stranded if your doctor's in another country.
Or you just got to stay in Costa Rica for 2 months.
That's probably the safest thing to do. And that's much more affordable, of course, than coming here and staying in San Francisco for a couple weeks.
Of course. And they'll tell you in Costa Rica, like, oh, we'll throw you up at the Four Seasons to convalesce for 2 weeks afterwards. And hey, you want an MRI while you're down here? You need one of those? We'll throw one of those in for free. Like, it's just like
it's
this
incredible.
weird.
It's not
really
too bad,
is.
man.
Yeah, it's like one of these like weird barter situations for stuff that just seems so foreign to us. You're like,
I think in a weird way, they're hoping they're going to find something else that you need to get treated down
no,
there.
100%. Yeah. They do a lot of dental work down there, like full mouth replacements and stuff where, I mean, I'm not a surgeon, so I don't know. You definitely know way more than us on this, but like feels like a relatively routine procedure. I mean, put the screws in your jaw and kind of screw in your teeth and kind of.
Yeah, I think it takes a really long time. And in America, that could be like $40,000, $50,000, but there it's much more affordable.
Yeah. It's like half the price, less than that. So like when you got into it, like did you go cosmetic, reconstructive? Like,
I was going to ask what your practice looks like now.
Right. So when I got into practicing in Louisiana, when I first came out, this is kind of typical of most plastic surgeons. They're doing mostly reconstruction because you're not getting the referrals for cosmetic work. Nobody knows who you are.
Sure.
So you're doing, and also as an employee of the hospital, that's really what they needed me for. Because remember, in 2007, that was 2 years after Hurricane Katrina hit New Orleans, decimated the city, shut down a bunch of hospitals. So a big part of the population came to Baton Rouge, where I was, which is one of the reasons they hired me, is they wanted me to take care of a lot of the reconstructive aspects of all of this new influx of population. So definitely mostly reconstruction to start, but over the course of 6 years, I started getting more referrals, doing more cosmetic work, Botox, fillers, breast augmentation, tummy tucks, things like that. And then by the end of the 6 years, it was really mostly cosmetic. And being an employee of a hospital is not conducive to a cosmetic practice because that's just not what the hospital's there for. So also when you start to do more cosmetic, patients are looking for their own operating room, and they're looking for like a VIP experience. They don't necessarily want to go to a surgery center where there's a bunch of kids who are getting their tubes and tonsils, done. They're screaming. They want a more a personal experience. So when it came time for me to get at my own operating room, the hospital wasn't really going to do that. So that's when I started looking around. And my wife and I found this practice in San Francisco. I actually found it on the American Society of Plastic Surgeons job listings board. This plastic surgeon in San Francisco had his own accredited operating room in his office, which was, of course, what I was looking for. And he was looking to retire. So we came out here in February of 2013, checked out the practice. It was legit. I could see the Golden Gate Bridge from the practice.
Love it. That's kind of cool.
It was amazing. It was in Pacific Heights, which is the fancy part of the city. And that wasn't really my primary driver, but it was just like kind of an added bonus that it was in a nice area. And so it was legit. And I've written about this before because nobody really talks about it, but he came up with a cost for the practice that was based on net revenue of injectables like Botox and fillers. And the reason he only did the valuation based on that is because he felt like, that's probably the main thing my patients are going to come back to you for is for injectables. If I've already operated on, they're probably not going to come back.
They don't need another surgery.
Right. Which ended up not being true. Thankfully, they did come back for more surgery. But so anyway, he came up with a net revenue based on injectables for the previous year and did a multiple of 2, which a multiple is just what you do whenever you want a bigger number. And it ended up being $191,000 to take over the
super
practice.
Reasonable.
And it was really reasonable, especially having your own accredited operating room. Exactly. So it was $191,000. Got an SBA loan for it. And we moved out here. I started in June of 2013. Wow. And then looking back on it, I was curious, how many patients of his actually came back to me because he left me at his database or whatever. And I looked at it after 5 years of being here. I took a snapshot and found that of the patients he left me, only 6.8% of them came back to see me the first time. So I want to be very clear. It wasn't that 90% of them came in to see me and then only 6.8% came back for a second visit. I'm saying that 6.8% were that was how many total gave me even a chance.
I wonder. I think that's probably a pretty good number across the board there with retention.
It's a good number. 6.8% is a good number if you're a plastic surgeon and you have these high dollar value procedures and services you're offering, because that translated into 312% ROI based on what I paid.
Wow.
6.8% is probably not good if you're a primary care doctor and you're getting all insurance payments and you're getting paid like $40, $50, $60 per patient. There's only so many patients you can see in a day.
Yeah.
So that was eye-opening and to see how many patients came back, and thank God it's been a good decision. But now, since I've moved out here for the last 11 years, yeah, it's been just cosmetics, tummy tucks, mommy makeovers. We have a board certified anesthesiologist that comes in. And so we can do everything legitimately in the office and safely. And now, fast forward, I've got this great nurse practitioner that scrubs in with me in surgery, and she knows what she's doing. She's just great, and it's just so dependable. Got great staff. But the thing that was really interesting that took another turn in my career is about 3 years ago, we noticed, the patients coming in for consults for tummy tucks, other body contouring procedures. They were not all, but a lot of them had their BMI was too high. They were too overweight. They weren't good candidates for surgery. And so my nurse and nurse practitioners said, you know what, instead of turning these patients away, can we start a weight management program so we can do coaching and phentermine and other meds that are available? And I was like, sure, that's fine. So this is 3 years ago. This is before the Ozempic craze and everything, or the Ozempic and Mounjaro went on an FDA shortage list before we were able to get compounded meds. So they started that 3 years ago. And then 2 years ago, that's when all these big name brand drugs, these GLP1s, went on the FDA shortage list, and then compounding pharmacies were legally allowed to make a duplicate of the active ingredient in those meds. So that's where you hear these names like semaglutide and tirzepatide. And then we incorporated that into our weight management program. And then we had a TikTok go viral. And then that's blown up ever since for our practice. But then what we've done with our practice with weight management, we've extended that to the Build My Bod, which became Build My Health, which is now Dr. Well by Build My Health. It's gone from price transparency to people being able to check pricing. Well, then it's reasonable for them to want to purchase things online. And so that's why we supported the e-commerce. And then people wanted to do subscriptions for Botox. So then we pivoted to support that. And then these medications for weight loss, those require a subscription that people, get their shipment every month. So we incorporated the weight management into the Build My Health platform. And now that's really kind of exploded for all of our providers using the platform now for weight and wellness programs, all these medications you get from compounding pharmacies on subscriptions. So that's why we're Dr. Well now. I just wanted to run through that to explain why that ended up being a natural evolution if it doesn't sound like it at first.
That's
definitely pretty amazing though, as far as, following the trend of what patients wanted, what they needed, and then developing, basically a tool to help them get that.
Right. I mean, because I always joke, but I'm also serious that these GLP-1s, these weight loss meds, they're the biggest thing since penicillin because they are totally transforming lives. I mean, of course, they were the first thing is that this class of medications has been around for 20 years. So everybody's always nervous. Oh, these are new. We don't know the side effects. Really, again, the class of drugs has been around for over 20 years. So we really do know a lot about the side effects. And they're originally for type 2 diabetes, but then they noticed they were helping patients lose weight. So then the drug companies got them reapproved by the FDA for weight loss. Now they're indicated for heart disease. They're eventually going to get indicated to help with sleep apnea, chronic kidney disease, fatty liver. That's why I say that they're bigger than penicillin, because they just have so many massive effects and benefits. And even with the current 3 indications, they're only indicated for 3 things right now: the heart disease, the type 2 diabetes, and the weight loss. But even that, there was a recent JAMA study that came out that said based on just those 3 indications, 136 million Americans are candidates for the medication.
That's crazy.
That's an indication from 136 million. It's only 330 million Americans.
Yeah. What does it do for your heart? I didn't know that.
Obesity rates, correct? I mean, essentially, is that what that's translating to?
It's a lot of so obesity leads to type 2 diabetes. So it's so that those are the 2 big ones. But then of course that all leads to cardiovascular disease, which they're already indicated for. The JAMA article has a pretty cool Venn diagram of these different circles and what's contributing to it the most. But it's really incredible how these they're huge. I mean, because they just treat so much, and then there's this thing now where they reduce inflammation, and nobody really knows what that means or how they do that. But it's pretty clear that people are getting benefits from these meds even before they lose the weight. So, for example, people are seeing the cardiac benefits, and you might say, "Oh, the cardiac benefits are because of weight loss." No, people are seeing cardiac benefits even before they lose weight, or they're seeing a reduction in osteoarthritis and joint pain even before they lose weight.
Is that just because of inflammation markers that are going down?
That's exactly. But how does it do that? They don't really know exactly yet why it's so why is a GLP-1 that is a naturally occurring hormone in your body that's released after you eat, how is that anti-inflammatory? But it's
right.
But how many anecdotal stories do you hear that you ignore before you realize there might be something to this.
What cardiac benefit is there? I actually hadn't heard that one. You said it kind of matter of fact, so I kind of feel stupid asking the question because I'm like, well, what the hell did I miss? Yeah.
No. So there was a couple studies that came out, these select studies that showed that that with these medications that they found that there was a 20% reduction. That was actually a big study, like 5 years, 17,000 patients, but there was a 20% reduction in major cardiac events like stroke, fatal heart attack, and non-fatal heart attack, and that's why they've gotten indicated now for cardiovascular disease.
Do they understand the mechanism there and what it's doing?
That is when they went into it thinking it was just going to be by reducing people's weight. It was going to lead to those reductions in cardiovascular disease and things like that. But that's when they realized in that study that people were seeing these benefits even before they lost weight. And that's when they've now introduced this anti-inflammatory effect that they don't fully understand.
So no change in plaque or anything like that. It's literally this anti-inflammatory function.
That exactly. So yeah, I mean the plaques. A lot of times, what happens if you are not contributing to cholesterol, like if you have a good diet and you're not adding to your cholesterol, or you're taking medications for that, then a lot of times with the plaques along the walls of your coronary arteries, they just sort of, I don't want to say they solidify. That might not sound right, but instead of being like squishy plaques, they sort of flatten out and they become firm, and you might not necessarily contribute to it, but it doesn't necessarily reverse those plaques.
I gotcha.
I see.
Whereas in fatty liver disease, they actually see some evidence that it's actually reversing some evidence of scarring and fibrosis associated with that.
Oh, interesting.
So it's different aspects. Of course, this is all still being developed. That's the thing that's crazy is I know I'm a plastic surgeon. I know I'm not an obesity medicine specialist, but all of this data, all of these studies are coming out now. So even the cream of the crop obesity medicine specialists that did a fellowship, they're still learning all of this new data at the same time with me, because it's all just like it's all coming out now, and we all are.
We're all sort of on the same ride, right? And look, I'm not. I just got off a whole thing myself for weight loss, not intentionally. It was actually in a little experiment for the show. And I think that I'm part of a group. Maybe it's my age, but I'm in my mind, there's only one way to go. It's like the way too hard work. Let's gut this thing out day after day, month after month. Let's make it happen. And this is very much easier than that. And I'm like, but I almost feel like between Catholic school and the time in the world I was born, I guess my body's just like, no, let's do it the way super harder way. This feels much better. But are we at all concerned, or are you concerned as a practitioner, 10 years from now, what all this flood of people just run in to plug their, to get injected with this stuff? Are we concerned at all, or do we have any thoughts about future events?
We are concerned. It keeps me up at night, but the difference is that, as I mentioned before, the class of medications have been around for over 20 years, and people say, oh, but but they weren't indicated for weight loss for 20 years. And that's true. But these medications, they're not like these amino acids look around at each other and say, okay, guys, we're only allowed to work for type 2 diabetes. We're not indicated for weight loss. So they work the way they work. And they clearly were working for weight loss, which back with the first drug that came on the market was Byetta in 2005. And it was clear that that was working for weight loss, because that's why they went and did more studies and got it indicated for weight loss. And under the name, the first drug that got indicated for weight loss, GLP1 that got indicated for weight loss, was Saxenda in 2014. So they recognized these medications were working back then. They've been following a lot of patients for a long time, a lot of clinical trials. Obviously, I'm worried about, we don't know what we don't know. But one of the things they did notice early on is that these medications had an increased risk of medullary thyroid cancer in lab rats. That has not translated over into humans over the last 20 years. And there is a good physiological reason now that they've done more studies, and they've figured out there is a physiological reason why a lab rat is at higher risk of medullary thyroid cancer from GLP1 stimulation, whereas a healthy human thyroid is not. And those are things we'll continue to learn. There was a study that's come out recently in this Journal of Translational Medicine that showed that the heart muscle, the mass of the heart muscle in lab rats was reduced with these medications, and that they were able to show that also happened in human heart cells. So you're worried is okay, we know these medications, just like any type of weight loss, can lead to lean body mass loss like muscle and bone, does it reduce the muscle mass of your heart? It's obviously a pretty scary thing if you're talking about cardiovascular disease. But what they found was this kind of an interesting delineation, that this distinction, that it reduced muscle mass of the heart, but didn't lead to muscle atrophy of the heart. So the heart still worked in lab rats. Now, this was the Journal of Translational Medicine. The idea of translational medicine, for people who don't know what that means, is basically you find things in the lab and then you want to see if they translate into clinical studies in humans. Like, some things work in the lab that have no effect in a real world population. So the thing that's interesting is this translational medicine study was showing that there's a reduction in heart mass in lab rats. So how is that going to affect humans? Well, I just mentioned that study, that select study that was 70,000 patients over 5 years, that showed that this actually improved cardiovascular disease with these medications. So in that sense, normally it goes to the direction of translational medicine to clinical studies. But in this case, we actually had the clinical study first. It showed that maybe what they found on lab rats in the lab, maybe that really doesn't have any clinical indications, clinical side effects that in the human population. But it's all stuff that I'm still worried about, and I can't be cavalier about it as a healthcare provider. But again, time after time, you hear in the news about these things that they're talking about, stomach paralysis or pancreatitis. These are all things that are actually included in all the paperwork that has been submitted to the FDA. So they actually do know about these things. And while there's serious side effects like gastroparesis or gastroparalysis and pancreatitis certainly are very serious, they are very rare.
Yeah,
So,
right. Yeah, because
I got to
you're
imagine
not
that
seeing smoking guns everywhere with that.
No, and as you look at this, everybody's jumping on the bandwagon. Everybody's getting on these medications. It's
everyone from the
people.
garbage man to your kids' principals on GLP1s.
Look, man, I will admit that I played with them via a peptide company. I'm one of the percentages that gets really horrible heartburn from it, though, and the benefit did not outweigh the
risk.
Side effect. Yeah.
Well, so now you're telling me about this cardiac thing, and my little nerd brain is running like a hamster on a wheel right now, because I'm like, well, I have left ventricular hypertrophy, and I'm wondering if maybe a healthy dose of some shrinkage wouldn't
help you out.
Wouldn't end up helping me out. I'm like, huh.
This is the case where shrinkage would be a good thing.
Correct. Yeah. I'm like, all right. And I found, no one told me when I was lining up to do marathons for fun that, LVH was like an actual thing that I'd never even heard of until he's looking at my EKG and he's like, see this little thing right here? Yeah. So this is this thing. And I'm like going through it. I'm like, fuck, I had enough to worry about before this. Now you got to fucking throw something else on the fire. Yeah. But now I'm like, all right, well, maybe we just little GLP this thing out of existence. I don't know.
I would definitely talk to your cardiologist about that. It seems like there's like a lot of good data out there that would suggest that actually would be very effective for you.
Yeah, that's interesting. Yeah, but see, and this is what I love about A, doing this show, but B, just having the curiosity like that Tom and I have that led us to do this show. That's how you have to be if you want to take a commanding role in your health, and it sucks. Not for me, it doesn't suck. But if you don't have this as an interest, this is torture. Let's be honest. Right. Our wives do not share our proclivities for this. And if you
God, man. I'm like, hey, hon, look, I ordered these vials. We're going to inject every day. She's like, the fuck we are.
Yeah. And then I tell my wife, I'm like, hey, listen, Tom showed me how to do this. And she's like, no, there's a guy down the street that's going to charge me like $600. I'm going to have him do it. And I'm like, yeah, but this is like nothing. And she's like, nope, we're all good.
Well, so that's actually an interesting thing is a lot of people are going to their doctors and getting their, sound medical advice from their provider, but they can't get the meds from them.
Now
they're going to the endocrinologist, their cardiologist, and they're like, well, they're with Kaiser, and Kaiser's not writing for weight loss. Maybe they're writing for Ozempic, but even then, I don't think Kaiser's going to be writing for it much longer because they just posted a $608 million loss in Q3. Most of it was because of increased pharmaceutical costs. And it's got to be these meds.
Yeah.
So what we're seeing is a lot of patients who are going to endocrinologists, primary care doctor, still being treated for their diabetes or whatever, heart disease, but because they can't get their provider to write for it, because either they're at Kaiser and they won't cover it, or because their regular and private insurance won't cover it, that they're then coming to us to sign up for a subscription for the compounded versions, so that they're still, yes, unfortunately they're having to pay out of pocket, their insurance isn't covering, but it's significantly less expensive. than paying over $1,000 a month for these medications.
Is that the rub for the compounding pharmacy? It's just cheaper?
It's definitely less expensive, and by law, it's got to be a duplicate of the active ingredient. That's the whole FDA mentality, is that regardless of what medication, not just GLP1s, but if the name brand drug is not available, they still want Americans to be able to get the name brand drug, and the only way that makes sense is if the compounding pharmacies are making a duplicate of the name brand drug, because like there's no point in making it if you can't really address the demand. If it's not the same thing, that does us no good. So by law, it has to be a duplicate of the active ingredient in the name brand drug. It's just significantly less expensive. And then what we've done for our practice and for all of our providers is part of the Dr. Well experience is that we do all the vetting of all the compounding pharmacies, whether it's 503A or 503B. And then we're getting the certificates of analysis, making sure they're getting the medications from an FDA registered manufacturer. So I know Tom was talking about a peptide company, but our whole supply chain is definitely on the up and up.
Yeah, Doc, the vials actually say for research purposes only on the side of them, but there is third party testing. There is I'm not that cavalier.
Yeah, and I'm not gonna say that they don't work, because I think they really do work. It sounds like it really worked for you because you were actually having bad side effects, and that wasn't because
I couldn't lay down for 3 days after I got to the 2.4 milligrams.
Wow. And so that right there tells you that it probably really was the real deal.
I saw benefits of it. I did not see, these stories of people dropping 60 pounds. I didn't have 60 pounds to lose, but at one point I'm like, I can't lay down for 3 days. This is not good.
So if you're on the semaglutide having those bad side effects, which heartburn is one of them for sure. What we found in our practice is that patients who are having side effects, we treat the side effects, regardless of whether they're on semaglutide or tirzepatide, which are the active ingredients in Ozempic and Mounjaro, respectively.
Yeah.
But if they're having the side effects on the semaglutide and then they switch over to the tirzepatide, they tend to have significantly fewer side effects. So if you ever want to try the tirzepatide, let me know.
Well, as it turns out, Doc, they've got a peptide for that too.
Just so you know. I've got the tab open at Prestige, and I just got an email that there's a Black Friday sale.
Yeah, exactly.
That's awesome.
Hey, let me ask you, Doc, what's the why are the lower ends of the socioeconomic spectrum not kind of doing more compounding pharmacy? Is it because it's not covered by insurance, or you would think that would be an allure to anyone?
I think that, yes, while compounding meds are significantly less expensive than the name brand, they're still not cheap. I mean, the name brand is over $1,000 a month, as I mentioned, but the compounding versions are, through Dr. Well or any of our providers, it can range from the lowest doses, which are less expensive, to the higher doses, which are more expensive. It can range anywhere from $200 to $500 a month. So it's still not cheap, but it's certainly more affordable.
More
so I think people it's certainly more accessible. It's not going to be accessible for everybody, certainly not the lowest socioeconomic level, but keep in mind that there are actually quite a few states, their Medicaid program, which is treating people who are under under the poverty line, that they are, Medicaid is covering these weight loss drugs for a lot of patients. It's going to eventually bankrupt those Medicaid programs, but as of right now, they actually are covering it. But certainly
that's an unfortunate
compounded
reality.
meds are much more affordable.
But it is kind of a weird state of existence, right? When you look at a society level and you say, well, we sort of have to fund this because it's a quick fix, if you will, for a big problem, right? It's a massive pandemic level problem, but it, like you just said, you said it's going to bankrupt it. I mean, I'm sure there's a lot going behind that, but at a root, I'm just guessing it's a volume problem, right? Like if that many people need it and it gets paid for, I mean, I think these systems weren't designed to give this thing to everybody. And
Yeah. So, I mean, it's like a game of chicken. So at some point, somebody's going to have to blink because the medications work. And, this is a big thing with RFK coming into Department of Health and Human Services, that, he's going to be a big proponent of trying to improve the food chain and making food healthier, which how can you argue with that? But it's going to have to be a two-pronged approach. You're going to have to improve the food chain, which is going to take decades. It's going to be a generational thing. But while we're doing that, we need to treat these patients with these meds because they really are so effective. But you're not going to, and people could say, oh, insurance should cover more of it, but they just can't cover it at this price. So eventually So this is a really interesting, I have this whole bar graph that I use in presentations that eventually they're push going to come to shove, the drugs are going to have to be reduced in price so that the insurance companies start to cover it. But then that's going to increase demand, and then it's going to go even more shortage.
Right.
And so that's why the compounding pharmacies are going to be able to continue to make these, because the medications are going to stay on the shortage list to some extent. And it's going to be a revolving door of that shortages, because it's not like they developed Ozempic and Mounjaro. They're like, okay, this is good, we're done. No, they're developing new medications that are coming out. And like retatrutide is one that's Eli Lilly's coming out with, that supposedly has like bariatric surgery type weight loss without the surgery.
Oh, geez.
And the compounding pharmacies already have the formula for that because it's patented. It's like, it's public knowledge.
Right, they already know.
So once that comes out in 25 or 26, that'll go on the shortage list, and the compounding pharmacies will start making that, and we'll start offering it. But right now you can actually get retatrutide from those research pharmacies currently.
Oh, that's interesting. You know, I have like sort of mixed emotions about this, like solve the food chain problem, because I agree with you that that's definitely a thing. And I mean, for example, my family doesn't have a lot of those issues, not because of any other reason other than we just don't eat like that. We don't have that lifestyle. We don't, but that is a daily act of volition on our part as parents and our part as adults. Like, it's a full-time job, right? Like the world is not on your side in this one, right? So if it comes down to taking a Mounjaro shot or eating better, like, I don't know many people that aren't going to go.
Like
it's human
very
nature.
American human fix. You know, like,
absolutely.
Let me do the easy thing.
Yeah, I always say that it's an American thing. It's a human nature thing and an American thing. I completely agree.
Well, I saw a whole thing that RFK did, and he's like, your doctor should be able to recommend a gym membership, and insurance should pay for that. I was like, okay, well, let's just talk about this. While we could agree with each other on that point, if the option at that same doctor is to get a Mounjaro shot or get a gym membership, what fucking person is going to go and say, you know what? I like that idea of spending the next 12 months at the gym for an hour a day. That feels like the right answer over this shot.
A week? One shot
seconds.
a week?
Like, and by the way, I could go from the doctor's office getting this shot to the drive-through at McDonald's. Okay, cool. Like, this seems like
it definitely, you know, Doc, how much do you think of this is, like, to Matt's point, almost like a Band-Aid fix here? You know, I mean, yes, we're getting people with a better BMI, better health outcomes, but at what, you know, I guess at what cost? You know, we're not changing our lifestyle.
Right. No, I completely agree. And that's why you have to really combine those two thoughts.
Yeah.
Yes, it's definitely a Band-Aid if you're just taking the medication and you're not doing anything else. But that's the thing, is that while we've been told diet and exercise our whole life is that's the best way to lose weight, it's really not the best way to lose weight, because your body set point brings your weight back up eventually. But that doesn't mean that diet and exercise aren't important. They're absolutely important. In fact, they're more important with these medications, because you're eating less, you're drinking less, so you got to make it count what you do eat. You got to certainly drink more to stay well hydrated, because that's what I think most of the side effects are from dehydration. But you need to have a high protein diet, because you're eating less. You got to make sure those meals count. And that's why, and people talk about, with the weight loss and medications, you have lean body mass loss, bone and muscle. Well, that's not some predetermined fate that you can't do anything about.
Yeah.
If you exercise, you'll
you
be
could
able to
just
maintain
go to the gym on top of this.
On top of that. And so that's what we're always very, very clear about that. It's also the right answer to say, if you're going to do these meds, you really should do diet and exercise together.
Right.
But people don't hear that other part of that recommendation.
I also feel like that's, you know, you said it, this is best outcomes, but it's also allowing that medication to work in its best format. Yeah.
No question. No question. I mean, like, I mean, I'm taking tirzepatide, you know, once a week, a low dose, and it's great. But I'm also, you know, doing hot Pilates and boxing throughout the week, and it's and it also helps that my wife, just by chance, cooks really well and cooks really healthy, and she's done that her whole life because her mom did it. So we just got lucky in that respect that we're not eating a bunch of junk food. But no, doing all those things together, that takes a lot of time and effort.
Oh, it's exhausting.
And it's exhausting, and you can't really say to people, well, you know, it's a moral failing that they're not doing all those other things together with their weight loss medication. You know, people have different priorities and different different stressors on their life. So
I think when you kind of feel like crap, how you know, like you're already losing, you're already in the hole, and now you're like, feeling guilted because you're not exercising enough.
Yeah.
Right. You know, so like to have something to break the cycle might just be good enough to generate that positive change.
And I think one of the
Good question.
messages that resonates with me, and the one that I kind of pass along to more people, like pretty much everyone I talk to, is like, look, it's not we're not going to shame you for not doing anything, but you should at least have a sober outlook on what those consequences look like. And we should be adult enough to have a conversation about that without you accusing me of body shaming you or whatever.
Right.
You know, I'm like, look, I get that you're sensitive. You're super overweight. You're not super healthy. This absolutely makes sense. But let's at least agree that we're not attacking one another here. Let's just have a real conversation, because that lack of ability to have that conversation with people. We have a pediatrician here who used to be my kid's pediatrician in our neighborhood. She goes, over half the kids that come in here have like a toxic BMI, and we are not allowed to say a thing, because as a practice, they realize that the backlash from these parents who don't want to be told that they were shitty parents and let their kid get 60 pounds overweight when your kid's only supposed to weigh 60 pounds, right? Like, you know, you can't, like, she said those conversations went nowhere. It's like, you know, like parents instantly went into fight or flight, and now you're not having a conversation. You're just yelling at each other. And I was like, and that needs to change.
And yeah, you can't have the conversation, and the other conversation you can have is the fact that these weight loss meds, specifically Wegovy, which is the weight loss version of Ozempic, that is now approved in 12 to 17-year-olds.
Oh,
and
Jesus.
We've seen amazing results in kids, but people are saying, oh, but the kids should be on these weight loss meds. It's like, okay, well, it's either they remain morbidly obese and become morbidly obese adults, or you try to break the cycle, as Tom mentioned, and see if you can get their weight down. And we've had adolescents who've lost 70 pounds.
That's crazy.
Over 6 months. And then they got off the meds and they're doing great. And I'll find it very interesting to see if kids can get off these meds and maintain their weight better than adults can get off these meds and maintain their weight. Because adults, it's shown that they their weight goes up they regain about 2/3 of their weight once they get off the meds. They don't regain it all.
What's
over that
the
first
event
year.
horizon for that, though? Like, is it weeks or months, or is it years?
Over the year. So that's 2/3 of their weight over a year. Yeah, they don't just regain it over like in a couple
and
weeks.
I'm assuming they're also looking at lifestyle changes, whether or not those are still in place, correct?
So that is a little bit depressing. So yes, so the Ozempic, like the Wegovy study, the one that Novo Nordisk did, they showed that if they had everybody, doing diet, exercise, and the meds, that they lost, like 15% of their body weight. And then they took a segment of those people, and then they stopped everything, diet, exercise, and the medications. And those people regained 2/3 of the weight over a year. And you would say, oh, that's
a little bit of a jilted study, though. I mean,
exactly. Like, why would you
you're not showing
everything off?
Yeah,
nobody's going to get off everything. So you're saying, oh, so it must be better. Not really. Eli Lilly did a study where they had patients on the meds, and they lost, they lost 20.9% of their body weight over the course of 3 months, and then they continued them for another year. And what they found that the people that continued for another year lost another 5%. But then the people who were doing diet and exercise, and then they removed the meds, regained 14% of their body weight. So you still regain some of your weight. I guess not 2/3.
Yeah,
but you still
which is
regain
still
some
better.
weight. It's still better. Exactly. I just don't want anybody to think that just because if you keep doing diet and exercise, you're going to stay at the same weight. That the data does not show that's the case.
And
so
that's
you do
crazy.
regain some, but not as bad as it could be.
But in the weight loss game, it's a game of like half, of
I mean,
inches, right?
This
like
weight
you're like,
set point is so weird of a concept too. That's a hard thing to kind of wrap your head around. Like,
it's like the thermostat in your hypothalamus.
So it's really
doing
funny.
diet and
I
exercise.
just went through this, and the point of their program was to reset your hypothalamic weight set. And like, goddamn, if they weren't right on the money. I mean, I'll be honest. I've been playing with it I've been off the program for probably about a month and a half, 2 months now, and I'll play with it. I got 2 kids that are heavily involved in soccer. So every weekend it's like a road trip to another soccer tournament, right? I've got 2 different soccer tournaments and 5 games this weekend. What do you think we're going to be doing? We're traveling around. There's going to be a Chick-fil-A in there. There's going to be a Royal Farms, like a breakfast burrito in there. There's going to be like, a Danish in there, right? So Monday morning, my set point's 172. Monday morning, I'll bet you I'm 174, 175. Right. You do one steak day,
Steak day.
apple and a steak and a good intermittent fast. Boom, next morning 172.
And they
like
stole that
clockwork.
right from the HCG diet. Like
No,
I love how creative they were, but they seem to have cherry picked from several different formulas.
And we're having them back on the show, and I can't wait to talk to them about that. But like that, there is something about that, because even if I don't do the apple thing, I'll go up to 175 on Monday. But if I just do nothing except for go back to eating what I'm doing, by Wednesday, I'm back at 172 anyway. Like it is a very interesting thing to watch. Yeah, the steak thing gets you there much faster. So like, again, in the weight loss game, it feels to me like it's about speed, right? Like speed is a primary motivator. So I think if that's your problem psychologically, then this is a great tool to have. But if you're just patient, you're not worried about like day to day, and you're looking at it candlestick over months or years, if this works long term, I'm going to be psyched, because this is not really like effort to me, right? Like, okay,
I was about
great.
to say that you feel like you can maintain it. Yeah.
No, it's very maintainable, right? Yeah. Now, granted, it took 8 weeks of like doing a lot of effort, but like that doesn't feel like a trade-off not worth it for a lifetime.
8 weeks versus a lifetime is very different too. Yeah.
But I am interested in like the wider lens that these things are bringing. You've touched on a lot of them here, but like that stuff is going to be continuously interesting, I think, for a bigger group of people. And at what point do you just say like, okay, well, this is just a society thing, like taking your vitamin C pills or something, like,
I do think that's the direction it's going, is that this is going to become more and more of a typical thing that patients are on, or Americans are on, because just the way you take the idea is to take an aspirin a day.
Sure.
I think this is going to be something people are going to start doing, but I don't know that you're necessarily going to have to take 1 shot a week 4 times a month. I think you'll be able to get to a maintenance program where you're doing 3 shots, 2 shots, or 1 shot a month. And I think that's a pretty reasonable trade-off, to take a shot every few weeks that kind of helps with cardiovascular health, helps maintain your weight. If it does, reduces inflammation. If people are feeling happier and better about it, it's kind of hard. And we don't see more of these potential side effects come to fruition. It's kind of hard to argue with that success. But there's really interesting, like big picture benefits that they're seeing, or that they're predicting, is that for example, if United Airlines, if all of their passengers lost 10 pounds on these meds, that they would save $80 million a year in jet fuel. There was a study done on that.
Wow.
Yeah. That's like kind of a funny study. It's like, okay, I can see how that would work. Maybe it'd be more than $80 million in jet fuel.
Now it's
the clothes are going to get smaller too, so they're going to need.
They're probably going to be able to pack more seats in, because people are going to be smaller.
Isn't that going to be the thing? Oh, we used to have 3 seats across, but now all you fucking people lost enough weight, we're going to make it 4. Yeah, like
right, exactly.
Yeah.
And then Goldman Sachs did a study where they found that if more people lost weight, or that it would actually increase the GDP by 1%. And the reason, and this is kind of a mean study, the reason it would increase the GDP by 1% is because it would reduce the number of obese people in America. And their argument was that obese people are more likely to call in sick to work, and that when they do come into work, they're less productive. So if they lose weight, they'll be less likely to call in sick, and when they get to work, they'll be more productive. It's kind of a mean thing to say about all obese people across the board.
It's a blanket statement, yeah.
It is a blanket statement. But you can look around, like the number of obese CEOs is like single percentage point. Like last time I checked, it's not common, right? Like you see these high functioning human beings, they're not generally large people. Like I know, and again, we're not talking in absolutes ever, but
sure.
Like if you look out across the land and you see 1,000 people, and 900 of them look one way, and a very small group.
Maybe it's all the cocaine.
It could be all the cocaine. Yeah. But like that is interesting too. And that's an intangible, right? Like I got through this program, and guess what? I don't do a lot of now when I go to Chick-fil-A with my kids on a soccer, like I am way more likely to get a salad without dressing on it than I ever was in the past, right? Not because of any other reason. Other than
Chick-fil-A is so good.
Matt, that sounds so fucking horrible.
It doesn't sound horrible. You got chicken on top.
A head of romaine lettuce.
Yeah. I mean, listen.
Iceberg lettuce. It isn't even romaine.
I mean, listen, it's not ideal, but like, you're working through, like, look, an egg and cheese at a gas station is still eggs and cheese, right? Like it's not, it's better than I don't know,
Yeah.
a cheeseburger for breakfast or fried chicken for breakfast,
Certainly.
right? Like, I mean, it's not much
Both
better,
of those
probably.
sound amazing to me, though. I'm not
I know
gonna
they
lie.
sound so good. And it's tough to walk past the fried chicken on your way to the
You
eggs.
put an
You're
egg
like,
on top of that burger, and we're golden.
So Doc, what's next on your horizon then? It looks like you guys are like really adaptive to change, and it seems like you've got your thumb on the pulse of this thing. Like, where do you see this going for you guys?
Yeah. So for Dr. Well, what we've kind of two things that we're working on is one is we're trying to make this make everybody understand that whenever you're signing up for these meds, GLP1s or any type of medication, that it's so easy to do with like a direct to consumer website, DTC, like a Row or a Hims. And that's great. We shouldn't just like poo-poo them like, oh, they're it's the fracture of healthcare and health, everybody's the health system by people going to one doctor for this or going to Hims or hers for this. But we need to embrace the fact that they've made things easy for consumers. They've become more consumer centric, with healthcare is definitely not. And so they've made things easy for them to sign up for different medication subscriptions. The only problem is that at the end of the day, the patient's relationship is with a website. And that's what we're doing with Dr. Well is we're taking that DTC model, putting that technology stack in the hands of providers in a provider to consumer model so that we're making it easy for providers to sign patients up for these medications. But now the patient has a relationship with the provider ongoing as far as, addressing any side effects like that. So that's one thing that we're doing is that we're really just growing our provider base. We have over 150 providers across the country now that are doing this. That's growing quickly. And so that's one thing that we're doing is just getting, and this is all providers, not just like plastic surgeons. We've got cardiologists, naturopathic doctors. We have OBGYNs, dermatologists, facial plastic surgeons that are doing this because, you might think, well, like, why is a dermatologist offering weight loss meds? But the thing is, when you start to realize that all healthcare providers are treating symptoms these days. They're not really treating the underlying cause, which is often obesity. So when a dermatologist is treating acne, maybe they should treat obesity, which will clear up the acne in a lot of cases. Where ENT or ear, nose, and throat doctor is treating sleep apnea. Well, if they treat the obesity, that'll probably get rid of the sleep apnea. So that's what we're seeing. So we're getting providers from all different backgrounds that are using our platform now. So that's one thing. But the other big thing that we're finding is that we are making all these electronic connections to compounding pharmacies. And if you think about a typical EMR, you go in, you can submit a prescription to CVS or Rite Aid pretty easily. Well, you can't do that with compounding pharmacies because there are all these mom and pop operations. They're so fragmented. But what we're doing with our system for providers, we're making it very easy for them to submit electronic orders to compounding pharmacies, and we're connecting to all these pharmacies. And so now we're going to end up being this clearinghouse for compounding pharmacies, which are going to make it easier for providers to use them, because normally a provider would have to call the compounding pharmacy, get an application, fill it out, get login credentials, have to learn their portal to submit an order for a prescription. But we're making that so easy now that more providers are going to use that. More consumers are going to learn about compounding pharmacy. They're not just for your pet, that they are for human medications too. And so that's going to be driving a lot of traffic to compounding pharmacies. And that's going to make us really kind of this hub, this clearinghouse for compounding pharmacies. So that's really our two goals: to become this major provider to consumer platform, but a hub and a clearinghouse for compounding pharmacies, basically all the non-traditional pharmacies in America. That's our big picture. That's our growth plan.
Which is super cool because like you're sort of like lifting up the covers on something that most consumers probably don't even know. I mean, I know a lot of smart people. I'll bet you less than half of them know what a compounding pharmacy even is.
It's true, but it's a very major part of the pharmaceutical landscape in America.
And you're making it easier for the small guys who don't have access or the infrastructure to flip to a whole, like, all right, now we can take this EMR, we can take that EMR. That's amazing.
Exactly right. So yeah, no, I'm glad y'all see it that way. But we're very excited.
Yeah.
And we've got a great
didn't even say AI today, which is super weird for us. We didn't say AI or psychedelics.
Yeah,
which is
I can use AI in a sentence if you want.
Yeah. But it's Tom and I are hardly the normal people, right? Like we have a show that talks about this. We get to talk to people like 2 a week. Usually we get to talk about some other new aspect that we never considered health before. So like, yeah, it's easy for Tom and I to think of it that way. Like I'm actually excited for you in the sense that I think you can get a lot of people to start thinking like that who aren't Tom and I. right? Like who
Well,
are
yeah,
not
I mean, coming
people
down to
that
are-
access too. I mean, it
Yeah.
just seems like a win-win for everybody involved, right? You're
Right,
taking away the headache from the physician where they don't have to go through the phone calls and everything. You're giving the compounding pharmacy more business, and you're opening this up to so many more patients.
right.
You know, so
Yeah.
where's the loss? You're going to piss off traditional medicine and traditional systems, but they're not doing the job anyway.
But you can't argue with the fact that we're providing more access
Yeah.
at a lower price point.
Yeah,
Sure.
I mean,
Yeah,
that's
yeah.
it. At the end of the day, it helps everybody.
You know what? Real quick aside, I do websites for a living for a long time. And like years and years ago when Botox got released, like where they broadened the scope of who could do that, there was this panic with plastics folks. And we did like a dozen plastic websites all in like 2 years because everyone went to this neck up philosophy from like, because they used to make all this money on Botox and they saw that go away. But I love that plastic people are so fucking smart about following these things, right? Like you don't really see that in other practices, right? Like you don't see your ENT on TikTok, like worrying about like how to market themselves to a broader market. But plastics folks really got their eye on the horizon on this kind of stuff. And I love that way of thinking.
I have to say, and this may not have been one of the reasons you would have thought of, but I think really one of the major reasons that is it's specifically cosmetic plastic surgeons, not the ones that are doing reconstructive, because the cosmetic plastic surgeons, they're not busy dealing with insurance all day. They're not busy submitting appeals. And so that frees up a lot of your time. I mean, dealing with insurance is horrible for the patient and for the provider. And I think that really frees up a lot of time not having to deal with insurance. And so your mind wanders and you think of other opportunities.
Oh, that's a great way of thinking.
Or your career.
That is a really interesting angle.
That's how it feels for me. I mean, just the fact, and also the fact that I have my own operating room in my office. I'm not driving around to surgery centers and hospitals all day long. I mean, my day is much more efficient than it is for most providers.
Interesting. Yeah, you're right. That's a bit of a different take, but it makes total sense to me, man. Cool. Well, let's tell people where to find you. Let's go through that.
So yeah, I'm Jonathan Kaplan. They can find me on TikTok and Instagram at Real Dr. Bay. That's RealDrBae, or at Dr. Well RX. And they can also just email me at Dr. Kaplan, DrKaplan at drwell.com, or drwell.com is our website. And that's for providers who want to sign up, but it's also where patients should go, drwell.com. And they can go to our provider finder page and they can see all our providers. We cover all 50 states, and they can get access to GLP1s, but also hair loss treatments, ED treatments, NAD, Samoralin, all these things that you can get.
Man.
Yeah.
And
all these different peptides.
We'll have to have you back for that one.
Absolutely.
I'm on that train right now to next. That's like my next mountain.
And you having a good experience with it?
I'm not using them yet. I'm actually, I don't know a ton about them, and I'm trying to build that corpus of knowledge before I kind of dip in. But it sort of
got a guy
does.
out of South America that can get us.
But yeah, it does. It's another one of those like domains where you're like, wow, we've got all this like really interesting research coming out about this, and like there's enough of a base there now where I feel like we could actually have like real data points, whereas like back up 5 years ago when it was kind of just starting to peak up a little bit.
Yeah.
It felt a little bit like, all right, how many of these guys did these in their basement? Like how many of these guys are legit? Like it just didn't have an air of legitimacy. And I think
now we can.
Yeah. Like we've kind of gotten over that now. So I feel like it's a good time to, I'm an early-ish adopter is what I call myself. Like, I'm like, all right, I don't want to be like the first adopter because, I'm not that guy, right?
My urine was blue long before a lot of other people, and I'm not even.
I'm like, I'm not that guy.
What is this? Like, oh, it was a joke in labs? Okay, let's give that a go.
Yeah, right. But that's another good one. Like Tom and I played with that. I went out and bought a bunch of like,
those trochees that were like,
trochees,
they were like,
And then it's funny. I learned a little bit about it, and we peel back the onion, and I look at the ingredients. I'm like, these don't even meet minimum therapeutic dose of any of these ingredients.
We talk about that all the time with semaglutide, because there is an actual oral version of semaglutide sold under the name Rybelsus. It's for type 2 diabetes.
Yeah,
it comes in a 7 and 14 milligram dose, but it doesn't work for weight loss. That's why. And so when you get these troches or trochees, there's just not enough of a therapeutic dose. And so that's why I always kind of recommend to our providers, like, don't start offering your patients those troches because they don't work and patients are going to get upset and they're going to write a bad review about you. They will eventually come out with some oral versions of the GLP1s that are high enough dose that are therapeutic, but I think they might actually have more GI side effects than people are.
Yeah, I was just going to say,
that
you
makes
can do
sense,
that,
yeah.
but then what? You're going to like take a guy like Tom and he's going to be breathing lava for a day? Like that doesn't
look, it was enough to put me off of it.
Yeah, like that doesn't make any sense. Yeah. I mean,
some of the oral medication they're testing, they showed that there was a great weight loss, like 15% weight loss with a daily dose of 25 milligrams of semaglutide. It was part of this Oasis 4 study. And so it showed that it had just as good a weight loss as the once a week injection, but it is a daily pill. It is 25 milligrams. But the thing is that you have to read the fine print. 88% of people had nausea. And
that's a lot.
My favorite part is that, and there were people who had vomiting, but it was mild vomiting. I don't care what kind of vomiting I have. It's the worst thing I've ever had. It's like the worst day of my life.
Right.
It's like there's no such thing as mild vomiting. Maybe mild nausea, but not mild vomiting.
And I love those commercials that are like, in some cases, bleeding of the perineum occurred.
Yeah,
like
the
just
4
casually mentioning this.
It's a 4-minute commercial. There's 30 seconds about the drug and a 3.5-minute warning.
Yeah, it's like, why didn't you lead with that?
Yeah,
Please contact your doctor.
Yeah, bleeding taint is sort of like an immediate dismissal for me. Like, I'm like, I'm not really sure that this goes.
I don't think we're going to top bleeding taint at this point.
No, definitely not. That'll be the one Riverside cuts out to
great point to
TikTok for real. Yeah. Well, Doc, it was awesome talking to you, man. I really appreciate your time, man.
We'll definitely have you back, man. This was a lot of fun.
Hey, maybe with the NAD stuff, actually, I'm really actually very interested about this. So
I'd love to talk about it. There's lots more to talk about. Anyway, really great, really enjoyed it, guys. Thanks so much for having me.
Awesome. Thanks, man.
Take care.
You guys enjoy the weekend.
You too.
Take care.